You're masquerading as RT. Just change the name on it, huh?
Yeah, I just changed my name. All right, who wants to go first? Or I can go first.
Go, Nelly.
Okay.
Button this should be record.
Okay. All right. This is a patient who came with pelvic pain.
Something wrong with vagina.
Yeah, there's a lot going on.
Vaginal vestibule. Tumor.
Yes.
No? No
Sorry,
tumor?
one more time. Can you say that again?
Like as you went down the vaginal vestibule, that looked like cancer, like tumor of some sort. Like if you go down.
Okay, let's see, go down.
Nelly, there's vaginal gel too, right?
Yes, there's vaginal gel. Let me see if this helps.
Yeah, it looks like the walls are circumferentially thickened in the lower vagina.
And then I'll give you the T2. She's got a lot going on.
Of contrast.
Yes.
Yeah, that's T1 pre.
Yes, that was pre, and here's contrast. 60 seconds.
Here's
Maybe
axial.
subtractions. Subtractions. And then if it helps here. So, well, I'll tell you what I thought, and feel free to add anything that. So where is the? Okay, so I thought there was endometriosis here. So these are T1 hyperintense here. Bilaterally, and I thought there was quite a bit of endometriosis too, deep infiltrating endometriosis. So on the axials, just thickening around there. There's some thickening here. Nothing that invades the bowel. Oh, and there's a big plaque here in the cul-de-sac right here. On the sagittal, I can see that better. Right there along the torus uterinus plaque of DIE. And then what I wanted to share, which I don't see very much, is this defect. So yes, I thought there was also like a prior vaginal trauma. It looks like there's a laceration here with this T2 dark scar that kind of traverses the entire wall of the vagina and perhaps the kind of like the levator support systems here. And then in addition, I thought there was also a defect here. There's like fat that herniates through the levator ani here on the right, asymmetrically. It looks like the trauma was probably somewhere on the right because that old vaginal laceration was also on the right here. So I wanted to share this really great paper that I found here. This one is paravaginal defects classification and tears in the paravaginal region. And there's a cartoon that I thought kind of represented what I was seeing. See here, where there's fat herniating and the kind of traversing, kind of defect through the levator ani here. But then the arcuate tendinous fascia pelvis, ATFP, the kind of the fascia surrounding the urethra anteriorly, that looked intact to me. So as I mentioned, there's quite a bit going on. I thought there was, endometriomas in DIE, and then there's like probably some old pelvic trauma here that led to some of these changes. The vagina also looks a little distorted too. It doesn't have the normal H-shaped morphology. So this is sort of what we're supposed to see is kind of a semi-H-shaped morphology of the vagina. And that looks a little distorted to me too. So sort of going along with the fascial defects.
Childbirth trauma, and maybe she had an episiotomy or something, right?
Yes, she has had a C-section before, and I didn't see a history. Wait, I'm sorry, did she have a C-section? I don't see the susceptibility, so I might be thinking about the wrong patient. But yes, some kind of trauma, like I didn't see, it's not, I mean, if there's something else that happened, that's not in the report, I mean, in the clinical notes. But yeah, I agree. I think some kind of like birth trauma, if she's, if she had children in the past, or something else. Yeah.
Nelly, is this in the spectrum of like transperineal hernias?
I don't know. I'll look it up.
Those we've seen some in the setting of like previous APR and such, but those are more closer to the midline. I think I'm not sure I've seen a paramedian one like this.
I mean, perineal. I mean, so I didn't see anything herniating like down.
Right.
So I don't know if this fits the perineal herniation. To me, it looked a little bit more kind of endofascial defects. So that's my case.
Okay.
Anyone? Tell me when to go.
Oh, ready.
Okay. So this is of course, a man who had a history, recent of really bad pancreatitis, and now his story is that they put, they did they put the stent, the gastrostomy stents, and patient has a lot of pain and fever. So, let's see. So I was looking through the case, and he has all these collections which were there before, and this collection, and this walled-off necrosis that he had before has, you can see has a lot of kind of air, which is, not non-specific because he has his gastrostomy. Then I started looking, kind of following the catheters, and it kind of looks very strange. So then, I looked at it back and forth, and I thought that the G-tube and G-tube kind of went here. And this is the case where, you know how we normally do 3D recons, and they're very pretty, but like, we already know what's going on, and just kind of like makes. But this is a case where I felt that it was really helpful. You can see that this is the stent, and you can see that the gastrostomy. You can see two stents as they're supposed to be, and this is gastrostomy, and now you can see that NG tube got tangled in one of the stents and actually went through gastrostomy. You can see here I took multiple pictures, from various things. So you can see that however you're going to turn it, that the NG tube passes through, through the gastrostomy, and it terminates not in the stomach but in the in walled-off necrosis. So all this debris in the walled-off necrosis is not just air. This is actually this feeds that has been coming through to him. So that was an interesting thing. All right.
Nice, Victoria.
Next.
I said it's nice that the 3Ds, we rarely look at them, but it is helpful.
I mean, I honestly, because I couldn't figure out how many catheters are in, and I was like going through, and I couldn't get. And on 3D, it's like immediately clear what's happening. So this is like one of the very few times when 3D is really helpful to us. I mean, I like making 3Ds so that clinicians can kind of figure out what's happening. But anyway, so the next case is a young woman who was found to have a pelvic mass on ultrasound, and she was sent to MR. You can see that she has a uterus, and here's the left ovary, here's the right ovary, and you can see that she has this very large, kind of heterogeneous, primarily T2 hyperintensive, some into more intermediate regions, and there was a stalk arising from this lesion. And let me just extend to the way. again, you can see that here's, it seems like that there is no really close line between the mass and the ovary. And here's the stalk, and it seems to be coming toward the uterus. And here's the contrast. Again, you can see that the mass kind of is heterogeneous, right? It has pretty interesting vessels. Anyway, so we pondered as to whether it represents a pedunculated fibroid or some sort of pedunculated ovarian thing, and I wasn't sure, but because it was so pedunculated, I thought it was uterine in origin. So my final report said that this, that I favored that this is some sort of ecdophytic uterine mass, in which case, you wonder if this is, just ugly degenerated myoma, and of course we can never, exclude leiomyosarcomas for this case. So the patient had surgery, and this ended up being just probably the largest fibrothecoma I've ever seen in my life. And the interesting part is that somehow, I still can't figure out how it connects to the ovary, but I guess the stalk somehow, connected to the ovary somehow.
It's not even very T2 low, right?
No, it was just kind of intermediate, right? So I guess this had more thecoma, probably component than fibrothecoma, fibrous component. All right, kind of sort of a companion case in the sense that this was also so the other person was 21. This patient is about in her late 40s. Same story. She came in because of pelvis showed a large uterus. And you can see that. You see, the uterus is enlarged, and you can see that there's a dominant mass, somewhat heterogeneous, and the walls weren't really that well defined on the T2. On post-GAD, it's arguable whether or not the walls are well defined or not. So you can see that the mass is quite heterogeneous. There was really nothing exciting in terms of, there was no hemorrhage, right? So in the mass. And so you go here, right? So it's very, very heterogeneous, really. So with this appearance, we did the usual, can represent, degenerative myoma, but because the margins were so ill defined, especially on T2, I kind of said, in this case, and you can see this dark vessels, that's also kind of one of the signs that was described, more glowing with leiomyosarcoma. You can see here, it just really doesn't have a great, well-defined wall. Anyway, so with this appearance, I said, in this case, really, we need to consider at least leiomyosarcoma. Did the whole, the usual, can't really tell apart. And
do you have the diffusion?
I do, unfortunately, probably not great, but you can see it like that. Diffusion is not as helpful, if with cellular leiomyomas, they can restrict. So it does restrict, but in a very homogeneous manner. So it's neither here nor there. Anyway, so with again, so the patient went for surgery, and this ended up being a STUMP, stromal tumor of unknown malignant potential.
Wow.
So it's sort of, I guess, it's on the spectrum, right? It's not quite leiomyosarcoma, but it's sort of kind of on its way, right? Am I wrong?
Yeah, I think those are neither true fibroids nor true leiomyosarcomas, somewhere in between.
Right.
Yeah, we had a case of, I said we had a case of one of these which actually grew in pregnancy too, ended up being a STUMP.
Right.
When I see these uterine lesions now, I referred to Fiona Fennessy. She published a paper in Abdominal Radiology about how to distinguish a leiomyosarcoma from conventional fibroid. And T2 signal was like one of the key features. But then when you kind of go through she has a little diagram, and you go through that workflow, it leads to something malignant. Like with this case, like because the T2 is the first branching point or the early branching point, and then like it'll direct you to leiomyosarcoma. My question is, and as you alluded to, Victoria, like how do you differentiate that from a hypercellular fibroid?
You can.
Right? Like it looks
So
very similar.
Yeah. So I have to look at the Fiona's. I think I quickly glanced at it, but there's a paper a few years ago where they did when they took a collection of leiomyosarcomas and leiomyomas, and they gave the mix of cases to a radiologist, and it was literally 50-50. AUC was 50%. So we cannot accurately distinguish between the two. The diffusion theoretically should help, but again, diffusion can be we can have restricted diffusion in cellular leiomyomas. So we can, I think it's a situation where we can raise the concern higher and higher, but I don't think we can accurately say one way or another. So
I think Aarti showed one also, right? Victoria earlier. Where I think Aarti talks about like that if there's more hemorrhage, more necrosis, more heterogeneity, that's
right. So there are certain signs, that are more associated more with leiomyosarcoma, like poorly defined wall, heterogeneous appearance, areas of non-enhancement. Obviously, if you see frank invasion, that's easy, right? Restricted diffusion, hemorrhage, like the more complex, obviously, and poorly defined it looks, the higher chances of leiomyosarcoma, but even with that, it's not,
We should start
also,
building a RADS system for this.
I was thinking the same thing.
I think the problem also is not a problem, but I guess it's a good or bad problem. But it's a good thing is that leiomyosarcomas are rare, right? So, it's the whole thing with with pretest probability and even right. So like because the pretest probability is relatively low, even when all the things fall into the right place from without Bayes diagram, right? Even if the imaging features are quite suggestive, the post-test probability is still going to be not that high. So
yep.
I think that's part of an issue. Okay, then next, let's see, I'm going to just put it here for a second. So the next one is young patient who came in with Cushing syndrome, and this is his MR, and you can see, it's not a eye test. You can see like a heterogeneous mass in a adrenal. And what I thought was interesting is the mass is relatively homogeneous, right? I mean, maybe there's a little bit heterogeneity superiorly, and here, here it is an arterial phase, here it is an foramen phase. Sort of for the degree of size, for given the size, fairly homogeneous. Maybe there's like some hemorrhage superiorly. Anyway, so this is taken out. You can see this enhances. It's not really even a hemorrhage. It's just kind of not. Anyway, so this came back as adrenal cortical carcinoma, which I thought was interesting because it's not quite. No, like the few cases that I've seen have looked much more aggressive than this.
I guess size is important too, right? If it goes over 4 centimeters.
Right.
Yeah.
Right. No. So it was going to come out anyway. But it's just interesting because the ones that I've seen, even when they're small, they've been like much more hypervascular and heterogeneous. This one's kind of like less ugly looking, but ended up being adrenal cortical.
Caught it relatively early.
Huh? Right.
Caught it
But
relatively early to what we normally see.
Right.
We
Except
them bigger and later.
Right. Right. But even like it's not small still, but yeah. But he's very young. He's like 40. So like 41, something like early 40s. So so it's a good thing that we managed to. But he presented with Cushing syndrome. That's how they caught it.
I have 2 questions.
Okay, that's all from me. Yeah, go ahead.
Sorry, I missed part of the discussion because I had to. It was adrenal cortical carcinoma. Is that what the diagnosis was?
Yeah.
Okay.
Yeah.
And then the second question was, when I had initially saw this, it made me think of this other adrenal lesion that we presented where we had bilateral homogeneously enhancing adrenal lesions. I think it was like oncocytic neoplasm or something like that of the adrenal gland.
Yeah.
And I
was
guess
not
how do you differentiate? Yeah. I guess there was internal hemorrhage. There was like hemorrhage in this case. So that's maybe like one way to.
I'm not sure it's hemorrhage, right? Because it is T1 hyperindent, but look, it's not black. So on subtraction, so it's not. It's
So
heterogeneous,
necrosis,
but
is that what it is then?
It's not really. It's just an area that kind of maybe that part is more aggressive. This
Gotcha.
part kind of washes out a little bit more. I'm not, but if it was hemorrhage, it would be black on subtraction, right? And it's not. So I don't know. I don't know why it has such an unusual appearance. Again, the few cases that I've seen have been much more aggressive looking than this, but it came out to. Hopefully he'll do well.
Great case. I have another case to share. Can I do that? Okay. Going to. I forget what I don't know, is abdominal pain or something like that. And what do you think? Let me do the axials.
Some abnormal bowel, maybe.
What about the hepatobiliary?
Bubble looks funny.
Yeah, it looks really funny, right? Yeah.
Is that just waist like thickening from adenomyomatosis or something else is happening?
Yeah. So there's this thing here, and then there's all these little tiny stones, and then there's I saw this other thing here, next to what I thought was a gallbladder, which I thought was here, and then this thing here. So I didn't know what that. Here, let me show you the coronal again. So then I saw this thing, plus, yeah, the stones, those tiny stones, and then that thing. So then I said, I don't know what that is, but so we got an MR.
Might be looking at colorectal cyst.
Still probably like a stenosing adenomyomatosis with, like Victoria said, the waist-like constricted part has compartmentalized the gallbladder. Unless there was a fistula or something previously which has just gotten loculated. But duodenum doesn't look angry. Don't see any large stones that would have passed down through like a fistula. So
yes, that's right. That's exactly what this thing turned out to be. And I'm going to show you because it's so there's one cystic. So there's the cystic duct is right here. There's only one right there, and it goes to what I had this pretty described with this cystic thing adjacent to what I thought was a gallbladder, and it is a gallbladder. And then there's this severe stricture from annular adenomyomatosis. You see these little T2 hyperintense spots. So this is the fundus.
Oh, wow.
And then this is a severe stricture that's obstructing because it's so severe. So these little stones are like obstructing it. So now there's acute cholecystitis, or sort of acute on chronic cholecystitis picture. There's edema, there's wall thickening, it's not totally happy looking gallbladder. And then these little stones, and this is probably another area of like focal narrowing, but the focal is right here. It's this little these little cystic findings. That's the annular adenomyomatosis, like Roopa and Victoria said, that led to this kind of just focal, like fundal cholecystitis.
The stick thing that looks separate is just the part of the gallbladder closer to the neck and the
neck. Yes, yeah, and that looked normal, and we know that was a neck because I could trace the duct to it, and the patient had cholecystectomy, and that's what the path showed, was severe stricture from annular adenomyomatosis.
This would be good to do Eovistone also, right, Nelly? It would have helped you with.
Oh, look what we got.
You did.
That's
So
pretty
there's
cool.
Eve is feeling
Nice. Yeah,
the proximal.
nice. Steve, do you have a case? If not, I have one.
You can go ahead.
Okay. Let me share screen. Okay. Do you see my screen?
Yes.
Okay. So middle-aged woman came in with sudden history of severe abdominal pain. And we did a CTA to rule out mesenteric ischemia. I pulled out the 1 millimeter cuts because this finding was really hard to see on the standard cuts. So I'll scroll through the area up and down. See if you guys find anything. Obviously looking at the vessels closely.
Thought there might be a dissection there.
Yeah, right. So we see a nice little flap here. Flap continuing here. I kind of lost it here, but then it came out, and see it's continuing to split this vessel here, which is one of the proximal jejunal branches. And then the branch below Steve, we thought had circumferential wall thickening, and the contrast just faded out for a short distance. So we wondered if there was a short segment thrombus like here, and then there is reconstitution distally. So bowel thankfully was unaffected, didn't see any bowel wall thickening, free fluid pneumatosis, no other signs of ischemia. Any thoughts on what you guys would have called it had you seen this for the first time? The patient was not hypertensive, no known underlying chronic medical condition, no trauma. So those were our usual questions.
And this is incidental?
She came in with severe sudden onset pain.
Oh.
Yeah.
Well, I mean, I would then in that setting assume it's acute, but it doesn't look like it has origin at the aorta, but just within the SMA.
Right, right. So that's kind of what we said too, is we think it's all these medium to small vessels which are involved. So we gave vasculitis as a differential. She had no known history. So she did get a full room workup and nothing turned up for vasculitis. And like I said, she was not hypertensive. There was no mesenteric trauma or anything. Then this is a follow-up they did the next day. And now we see a new finding.
Some connective tissue diseases make him.
Yeah, we excluded all that. So great thoughts, Ehlers-Danlos, Lois, Dietz, all those things. Nothing was positive. So follow-up scan showed a new common hepatic dissection. So working diagnosis was still some kind of vasculitis or no, they ruled out all prothrombotic states either. And this was more a dissection, although there was a short segment thrombus in one of the vessels. So none of her workup came back positive. So we consulted our IR people and they suggested to us the diagnosis of SAM, which is segmental arterial mediolysis. So they went with that working diagnosis because it's a condition that affects small and medium-sized vessels. Here, I'll share my PowerPoint in a second. So right now, the working diagnosis for her is still SAM. So SAM, yeah, it's idiopathic. We don't know why it happens, but it had quite a few findings that she presented with. There was like vessel wall thickening. There was a focal dissection. We didn't see any aneurysm. She was a good age. She was 47, female. So pathologically, apparently, this is like just vacuolization and lysis of the layers of the vessel wall, which is where the wall becomes weaker. Cookie and Co did this nice study which showed the incidence of SAM in different vessels. So ours was in the SMA territory and some of the lesser affected vessels. And like you guys said, we thought of all the usual things. FMD was the other one that the IR people thought of also, but that's supposedly in younger patients. And we know FMD affects renal arteries much more commonly. And by their mid-40s or so, most of them will have hypertension. So all her rheumatologic workup was negative. She didn't have any atherosclerosis, hypertension, connective tissue, nothing. So working diagnosis is still SAM. So this was something I had forgotten. I think we had seen some case of the day at RSNA a few years ago of this. It was a good reminder to think about this entity again.
So is it diagnosis of exclusion? I mean,
Sort of, I think, Nelly,
workup was negative.
Yeah, I mean, we did everything. We did all the workup for the usual causes and nothing came back positive. And there was progression from day 1 to day 2. It involved actually, it turned out there was an outside study. So even before she had that SMA dissection, that thrombus had come on day 1. So thrombus on day 1, focal SMA branch dissection on day 2, then that focal hepatic artery dissection day 3. So apparently that's a pattern known to happen with SAM. So something to think about when we see vasculitides-like picture, but the rheumatologic workup is all negative.
Could that diagnosis, do you know, be established definitively with pathology resection, like a?
Yes.
Right, but you didn't do that in this case.
Not yet, because she's held on stable with just these 2 vessels. Yeah. And the vascular colleagues told us if these things progressed and bowel had become ischemic, they would have gone in and stented it at first, put her on, she got on anticoagulation anyway for that short segment thrombus, but they're just now watching her and this is the working diagnosis.
Yeah, that was really cool. I just found another acute case if we have time.
Yeah, we do.
Yep, and I have another case too to follow, Victoria.
Right. It's not it's just acute cases, and like, so the patient was sent to it in about mid-50s, was sent to us with the diagnosis of abdominal pain, weight loss, new diabetes. Okay, so patient has hepatic steatosis, right? So, and here's the pancreas, and ta-da! It was just a very acute case of a functional neuroendocrine tumor.
Nice.
It's just the imaging is, you know, not that exciting, but the fact that all the clinical picture like totally like fell into place as it would like on the stem of a question was awesome. Like, she has new diabetes, she has steatosis, she has weight loss. So I thought it was pretty cool.
Nice. It blends in well with the splenic artery. So if you don't pay attention, it's missable.
Yeah, absolutely.
Okay, I'm going to share a renal case. Okay. So this is a patient who presented with a renal lesion. This is that was seen on a CT, and we got an MRI for further characterization. This is the lesion right here on the CT. So this is the pre right here. It was a CTU, so we don't have arterial, but we have nephrographic. And then we saw the delays. Okay, great. So then we got an MRI, and this is what the MRI looks like. So here's our T2.
Very heterogeneous, Nelly, on MR.
Yeah, it is very heterogeneous. Yeah. T2 hypointense, heterogeneous. Here's the pre. And that's not it. It's ISO there. Enhancing. And then here's the delayed. There was washout, and then diffusion. Diffusion, it restricts. So
we have to use our calculator app here.
Here, let me see. Here we go. And then let me give you the ADC right there. It's a little bit more obvious on the ADC. Right there. And then right there. Right there. Yeah, so that's right. I did the calculator.
Okay.
Yeah, and
Wait,
first of all, I gotta tell you,
again?
contrast, yes.
Looks like there was washout.
Here's our, here, let me put it on 4
Yeah.
so that we can see it a little bit easier.
So the washout looks significant just visually. I don't know what numbers you got.
Yes, there is enhancement. Let's see. Here. And there's washout. Yeah, I also measured washout. And I think I mentioned it's T2 kind of darkish, heterogeneous. And then the restriction, there's I thought there was is it diffusion impedance restriction right there. So what do you guys think? Like, what would be
You
your?
look at the calculator.
I'm biased because I've seen your tweet, but I can't wait for you to show us the calculator.
Okay, first of all, I use the, we've been having the CCLS talks last few times, and that paper that just came out, the multi-center assessment. Did you guys see that?
Yeah.
Yeah.
It
was impressive. Yeah. It was published in Radiology, I think, like 2 weeks ago or something like that.
It's the second one. Second one.
Oh, the second one? Oh, yeah, there you go.
Yeah.
Perfect. Yeah. And so that's what I did. So I did it, and it got me to so you could, if you don't know what the enhancement is, you could just put the signal of the tumor and then the cortex, and then same thing for the enhancement. You just take ROIs, and then it'll automatically calculate for you. And then it gave me lipid poor AML. Lipid poor AML.
So most diagnosis.
What?
That was the most likely diagnosis.
Yeah. Yes. So the thing is, Ben, you got to give them a number, right? Like, what does CCLS of 2 mean? And so then I went ahead and took the multi-center data. There's a beautiful chart here. And so CCLS2, it comes out to be like 40% are CCRC, clear cell. I mean, which is still pretty high. Like, it's crazy that CCLS2 has a higher, but I mean, the confidence interval is pretty high too. So, and we know that, right? There's just increased variability the lower the score. So I gave them a CCLS2, and then, I mean, normally, right, I would say this is lipid poor versus clear cell, and they'll just usually take it out. But now I can give them a number, which is 40% likelihood of CCRC, clear cell. And so I recommended a biopsy.
Nice.
We'll see what the pathology shows. But it didn't, like, I was a little worried because the T2 wasn't totally homogeneous, right? I'm like, I want lipid poor AML to be a little bit more homogeneous, and it wasn't. So that was the only thing that kind of surprised me, or kind of made me a little bit more worried, than typical. And then the other thing is, and I think like Arti had kind of raised it, presence of diffusion restriction leans you more towards lipid poor AML compared to clear cell. So yeah, DWI restriction is a good thing. And the other thing I didn't know was about the ADAR, like the differential enhancement. So with the CCLS calculator, clear cell, Victoria, I'm going to mute you because I'm here's, I think you might be dictating. With the clear cell, it washes, there's wash in and washout. And that is less with lipid poor AML. It enhances, and there is washout, but it's not as much washout as clear cell RCC. So those are like these small nuances shifted it towards lipid poor AML over clear cell. So the diffusion and then the intensity of washing and washout. So it's very helpful, actually. Yes.
There's this thing with reversal.
Oh yes, there was also that. I didn't see the reversal. Go ahead.
Did you? I could never get it. Like I could never understand exactly what it means. Did you? Do you ever get it? Like.
Arti showed a really nice case of segmental inversion. I don't have a good example, but she does, and it's like the area doesn't enhance, but then that segment enhances later. So I think they call that segmental inversion, and they see that in oncocytomas. But
so it can be. So you can't have that and washout, right?
I think it's
so, but I'm
you
not
have
sure.
either or, right?
Correct. I think it can concomitantly.
Because with segmental inversion, I always thought whichever parts don't enhance are the ones that enhance. So it's like an exact, like a mirror image later. But the washout can be a little more heterogeneous, right?
I don't know.
We have to read up some more, maybe.
Nice. Yeah, and I use a calculator and I'm so impressed with it. I mean, it's pretty like streamlined because subsequently I had an ovarian case. So I went online to do the ORADS calculator, and I'm like, oh, why can't it be as easy as a CCLS calculator? So kudos to Ivan and his team for putting that together.
For this particular case, you suggested biopsy, and has that happened?
Oh, not yet. Sorry, I just got excited over the weekend when I read this. So waiting for the biopsy results to come back.
Well, if it comes up with something surprising or different than one of those two diagnoses, you can let us know. But
oh, I will. And you know, the multi-center study, 40% still turns out to be clear cell, which is not an insignificant portion.
but helpful in guiding patients to not pursue a big surgery if it's not necessary, huh?
Absolutely, right. And that's what Ivan's argument was. Like when I saw him at SAR, and I'm like, you know, I promise I will use CCLS one day, not today, but one day. and I'm like, you know, it doesn't help me narrow the diagnosis. And he's like, well, if you now that you have a number, right? Like now you leave it up to the patient, right? You have a 40% chance of a malignant lesion. Will you now proceed directly to partial nephrectomy, or do you want to work it up, right? Make sure it's not benign.
That's what they said about the Bosniak ones too, right, Nelly? They said, we only keep saying 50% of them are malignant, but what about the 50% that are benign and you're doing unnecessary surgery?
That's exactly right. I mean, and if it was me, if I had if the benign, you know, in that like CCLS2, it's 2, right? I mean, 60% presumably benign or non-clear cell, like presumably, you know, lipid poor or whatever. I mean, I would want a biopsy. Like I wouldn't go straight to a partial nephrectomy or ablation.
I think it's going to be a long adoption phase for urology.
They're getting better though, Steve. They're much less hesitant to biopsy things now than they used to be. They never used to want to biopsy anything, right? But I think even in their world, we see at least our oncologists a lot more willing to biopsy. If we on imaging can give them even that 50-50 chance, they will biopsy. So
Yes.
yeah.
Our urologists are very perceptive. I mean, they're amazing. And so I had presented the CCLS paper during our GU conference, and now I'm starting to see like more MRs, right? So like the referral was one of our renal urologists, and so now he's really kind of now doing more characterization with MR because of CCLS.
Yep.
But you're right, it needs to be studied, right? Like, I mean, the adoption, all of that, and I mean, I suspect the data will eventually emerge. It would be like prostate. The adoption rate is like 5 to 10 years.
Yeah, exactly. It took a while for. Now it's like they're coming on with both feet.
I think that's all we have, right?
That's it for me.
Okay,
Yeah.
that's it for me too. Thank you guys. Nice cases.
Thanks, everyone. Have a great day.
Bye.
Thank you, guys. Have a